Podcast 2 of the upper limb series, the muscles of the back and shoulder region. This podcast is going to detail the muscles, their attachment and innervation of the back and shoulder region. The muscles of the back can be divided into two groups, either extrinsic or intrinsic muscles. The intrinsic muscles are the deep muscles of the back, and I'll discuss these in a later podcast. So let's start with the extrinsic muscles, and then we will detail the muscles associated with the shoulder region. The extrinsic muscles of the back are also known as the posterior axio-appendicular muscles, as they attach the axial skeleton to the appendicular skeleton. So for the upper limb, they attach the vertebral column to the pectoral girdle, which includes the scapula, the clavicle, and the humerus. The posterior axio-appendicular muscles of the upper limb can be further divided into a superficial and deep group. The superficial group comprises trapezius and latissimus dorsi, whilst the deep group comprise the rhomboids and levator scapulae. So let's detail the attachment sites, innervation and movements of these muscles. So starting off with trapezius is a paired, triangular shaped flat muscle that covers the posterior aspect of the trunk and neck. Together, both trapezius muscles form a diamond shape, and this is where the trapezius gets its name. Each trapezius muscle is comprised of three groups of fibres: superior, middle, and inferior. The superior fibres run inferiorly from the superior nuchal line, the external occipital protuberance, and the nuchal ligament to the lateral third of the clavicle. The middle fibres run laterally from the nuchal ligament to the acromion of the scapula, and the inferior fibres run superiorly from the spinous processes of the C7 to T12 vertebrae to the spine of the scapula. It is innervated by the accessory nerve, which is the 11th cranial nerve, and is responsible for numerous movements depending on which fibre groups are activated. The superior fibres elevate the scapula, whilst the inferior fibres depress the scapula. The middle group of fibres will retract the scapula. Due to their attachments, the superior and inferior groups of fibres can also rotate the scapula superiorly. Position inferior to trapezius is latissimus dorsi. Latissimus dorsi is a flat, large muscle that covers a wide portion of the lower back and acts directly on the glenohumeral joint. Its fibres run supralaterally from the thoracolumbar fascia and the iliac crest to the floor of the intertubercular groove of the humerus. Remember, the intertubercular groove sits on the anterior surface of the humerus between the two tubercles. At its origin, the latissimus dorsi muscle is extremely wide, but as it runs supralaterally to the humerus, it narrows at its insertion point. It is innervated by the thoracodorsal nerve and is responsible for a wide range of movements, including extension, adduction, and medial rotation of the humerus. Deep to trapezius and superior to latissimus dorsi are the rhomboid muscles, rhomboid major and rhomboid minor. These muscles, as their name suggests, are rhomboid in shape and run from the vertebral column to the medial border of the scapula. Specifically, rhomboid minor is the narrower of the two muscles, running laterally from the spinous processes of C7 and T1 to the medial border of the scapula above its spine. Rhomboid major is wider and is positioned directly beneath rhomboid minor. It also runs laterally from the spinous processes of T2 through to T5 to the medial border of the scapula below its spine. Both rhomboid muscles are innervated by the dorsal scapular nerve and are responsible for retracting the scapula and also rotating the scapula inferiorly, which depresses the glenoid cavity. The final posterior axio-appendicular muscle that I'll detail in this part of the podcast is levator scapulae. Levator scapulae is a narrow strap-like muscle that runs inferiorly from the transverse tubercle of the C1 to C4 vertebra to the superior aspect of the scapula's medial border. Like the rhomboid muscle, levator scapula is supplied by the dorsal scapular nerve, and like its name suggests, elevates the scapula and can be assisted by the inferior fibers of trapezius. It can also assist the rhomboid muscles and rotate the scapula and depress the glenoid cavity. Alongside its action on the pectoral girdle, levator scapulae can extend the neck when acting bilaterally and cause a lateral flexion of the neck when acting unilaterally, with the neck deviating to the activated muscle's side. In the second part of the podcast, I want to give details about the scapulohumeral muscles, that are a group of short muscles which extend from the scapula to the humerus and therefore act on the glenohumeral joint. There are 6 scapulohumeral muscles. These are deltoid, teres major, teres minor, infraspinatus, supraspinatus, and subscapularis. Out of these 6 muscles, the final 4, so that's teres minor, infraspinatus, supraspinatus, and subscapularis, are known as the rotator cuff muscles. So let's start with the deltoid and teres major muscles, and then detail the rotator cuff later on. So deltoid is a thick, strong, and triangular shaped muscle that covers the shoulder joint and takes its name from the Greek letter delta. Like the trapezius muscle, deltoid can also be divided into 3 fibre groups: anterior, middle, and posterior. All 3 of these groups run inferiorly to converge on the deltoid tuberosity, which is a third of the way down the lateral surface of the humerus. However, the 3 fibre groups all have different origins. The anterior fibres extend from the lateral third of the clavicle, the middle fibres from the acromion of the scapula, and the posterior fibres from the spine of the scapula. Due to these attachments, it is clear that the deltoid muscle forms the bulk of the tissue that surrounds the glenohumeral joint, with all 3 groups of deltoid supplied by the auxiliary nerve. The deltoid muscle can act either unilaterally, with separate movements controlled by different fibre groups, or as a single muscle, with all 3 fibre groups contracting simultaneously. So working unilaterally, the anterior fibres flex the arm, the posterior fibres extend the arm, and the middle fibres abduct the arm. All of these movements occurring at the glenohumeral joint. Working together, the 3 fibre groups abduct the arm, primarily by the middle fibres, with the anterior and posterior fibres acting as supports, much like guy ropes on a tent. However, in the fully adducted position, the deltoid's line of pull is in parallel to the axis of the humerus, and this pulls the arm upwards. For deltoid to abduct the arm, it relies on either supraspinatus to initiate abduction, with deltoid assisting once 15 degrees of abduction has occurred. Alternatively, the individual can lean to the side and allow gravity to abduct the arm for deltoid to then take over. So deltoid is made up of 3 fibre groups, anterior, posterior, and middle, and is primarily responsible for abducting the arm. The other scapulohumeral muscle that does not form part of the rotator cuff is teres major. Teres major is a rounded muscle that runs supralaterally from the inferior angle of the scapula to the intertubercular groove of the humerus. It is innervated by the lower subscapular nerve and is responsible for medial rotation and adduction of the humerus. So to finish the podcast, let's now turn to the scapulohumeral muscles that form the rotator cuff. The rotator cuff is a musculotendinous ring that runs around the glenohumeral joint and is continuous with the joint capsule. It serves to protect and stabilise the joint. As deltoid and teres major attach to the shaft of the humerus, they do not contribute to this ring and are therefore excluded from the rotator cuff. The 4 muscles are supraspinatus, infraspinatus, teres minor, and subscapularis. An easy way to remember the rotator cuff muscles is to use the acronym SITS. This uses the first letter of each muscle within the group, so that's supraspinatus, infraspinatus, teres minor, and subscapularis. So let's detail the anatomy of these four muscles. So supraspinatus, this muscle sits on the posterior surface of the scapula, superior to the spine in the supraspinous fossa. Its fibres run laterally to the greater tubercle of the humerus and is innervated by the suprascapular nerve. It is responsible for initiating abduction up to the first 15 degrees and then assists abduction of the arm with deltoid. Infraspinatus, as its name suggests, originates inferior to the spine of the scapula in the infraspinous fossa, and like supraspinatus, extends laterally to the greater tubercle of the humerus. It is also innervated by the suprascapular nerve and is involved in laterally rotating the humerus. Teres minor arises from the lateral border of the scapula and extends laterally towards the greater tubercle, inferior to the attachment of infraspinatus. It is innervated by the auxiliary nerve and, like infraspinatus, is involved in laterally rotating the humerus. The final rotator cuff muscle is subscapularis. This is a triangular shaped muscle that is unlike the other rotator cuff muscles, as it sits on the anterior or costal surface of the scapula. It extends laterally to the lesser tubercle of the humerus. It is innervated by the subscapular nerve and is involved in adducting and medial rotation of the humerus. Alongside each muscle's specific action on the humerus, all four rotator cuff muscles are responsible for stabilizing the humeral head in the glenoid cavity. This is an important feature of the rotator cuff muscles, as the glenohumeral joint has a relatively shallow glenoid fossa. And although this offers an increased range of movement compared to, say, the hip joint, it is less stable and more likely to dislocate. I'm going to detail the joints of the upper limb in podcast 12 of this series. So to finish this podcast, I'll just remind you that there are four posterior axioappendicular muscles: the trapezius, latissimus dorsi, rhomboids, and levator scapulae. There are 6 scapulohumeral muscles, including deltoid and teres major, supraspinatus, infraspinatus, teres minor, and subscapularis, with the final 4 forming the rotator cuff. In the next podcast, number 3 in the series, I will look at the location and contents of the axilla.